And I have two housekeeping. My name's Elizabeth Tish Murphy, and I'm the host for Dr. Noel Bairey Merz talk today. And there are two housekeeping issues I'm supposed to deal with. One is for CME credit. If you want CME credit, you have to text that number 50122. And the second housekeeping issue I'm supposed to deal with is for those of you who are online, if you have questions for the speaker, please use the Send Live Feedback button on the video cast page. All right. So now that we have the housekeeping issues done with, I'll go ahead and introduce today's speaker. It's my great pleasure to introduce today's WALS lecturer, Dr. Noel Bairey Merz. Dr. Bairey Merz is the professor of cardiology and medicine at Cedars-Sinai Medical Center in Los Angeles, and at Cedars-Sinai she heads up the Barbara Streisand Women's Heart Center, and she's the Barbara Streisand, I think, professor of cardiovascular medicine at Cedars-Sinai. She received her undergraduate degree at the University of Chicago, her medical degree at Harvard Medical School, followed by internship and residency at University of California, San Francisco, and then a cardiology fellowship at Cedars-Sinai. She's chair of the NHLBI-sponsored Women's Ischemic Syndrome Evaluation, known as the WISE study, and this investigates methods for effective diagnosis and evaluation of ischemic heart disease in women. She's published more than 300 peer-reviewed papers and over 150 reviews and chapters, and she has numerous awards and honors. And to give her time to give her lecture, I won't mention all of them, but I'll just mention a few. One is she's the American College of Cardiology Bernadine Healy Leadership. She received this award, the Leadership Award in Women's Cardiovascular Disease in 2016. She also received the Red Dress Award for Leadership in Cardiovascular Research in Women. In addition to her exceptional scientific accomplishments, she was also ahead of her time and a pioneer in raising public awareness of the need for more study in women's health issues, especially women's cardiovascular disease. Among the many things she has done to get the message out and raise awareness, she moderated a national Red Dress Awareness Panel discussion at the Ronald Reagan Presidential Library with First Ladies Laura Bush and Nancy Reagan, and this was in 2007. She also has frequent appearances in the media, and she's appeared in many television appearances, such as on 60 Minutes, The Today Show, Good Morning America, NBC Dateline in 2020. And so I think we're in for a treat with her lecture today. So if you could join me in welcoming Dr. Bairey Merz, who will give a lecture entitled, Not Your Father's Heart Disease, the Herstory, and the NHLBI WISE. Thank you.
We're going round robin. So thank you so much, Dr. Murphy. And yes, I am delighted to be here. The National Institutes of Health is just really the mother of all of the biomedical discovery, and not to say that it's always done in the United States, but it's just an honor to be here and such wide-ranging impact of this institute. So Dr. Murphy had it right. I'm going to talk about Not Your Father's Heart Disease, and this is the Herstory. I did not come up with this, a male colleague did, and the National Heart, Lung, and Blood sponsored WISE study. These are my disclosures. Of course, we always disclose. These do not have anything to do with what we're doing today, but those are my disclosures. So why was the WISE, the Women's Ischemia Syndrome Evaluation, funded? It was initiated by National Heart, Lung, and Blood. I will be talking about those project officers in a subsequent slide, but they were responding to this slide, where for the first time ever in the 1970s, as a country, we started sex stratifying diseases, and in particular cardiovascular disease. And what you can see here is the red lines are the female CVD mortality, and these were adjusted for age, adjusted for all of the things that might contribute to this. So these are true sex differences. Compared to the male line, CVD mortality, in the blue. And what we see was, for the first time in 1984, cardiovascular disease became the majority of victims were female. in our country. And this was quite surprising. This hadn't ever happened, at least in recorded history. I'm going to tell you a bit about the Yentl and the Yentl syndrome, which Dr. Bernadine Healy, a prior director of our NIH, coined in the New England Journal. It took about 12 years to start the Women's Ischemia Syndrome Evaluation. Again, the acronym is WISE, by National Heart, Lung, and Blood. The American Heart Association also, as we heard, started their women's awareness campaign. The joke, of course, is if it had been anything to do with erectile dysfunction or the prostate, probably wouldn't have taken 12 years, but at least we did get going. And it's coined by this cartoon, of course, the male physician speaking to his female patient. We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anybody. And that really was true at the time. So here are two WISE project officers, the Patrice, Dr. Nickens on the left, Dr. George Sopko on the right. And what you can see is what was initiated as a contract, and these original sites were contracted, so working hand in hand with National Heart, Lung, and Blood. We designed, there was this idea about what we were supposed to study. We were supposed to respond to this epidemic of death in women that was not understood at all. And what you can see subsequently is a tremendous number of additional NIH funding, as well as some industry partnerships, and I will show you all the way to translational what we consider bench to community randomized controlled trials of strategies to, again, address this epidemic of death in women. At the get-go, and remember this was in the 1980s, diversity, equity, and inclusion, which was not called that then, but design and from inception, 1996 through the current, the WISE studies oversampled ethnic minority groups. We did that by choosing our sites carefully. We oversampled low SES, again, to be representative to the American public. And we included detailed quality of life and what we would now call PROMs, right? Patient-reported outcomes, because being alive and being dead is not always the end of the game. And so we're pretty proud of that, of our diversity and our representation to American women. So I'm going to start now and just tell you sort of how this study progressed, because as you can see, it's a pretty old study, although it keeps renewing with new aims. We initially addressed a paradox demonstrating that women have a twofold increase in what's considered at that time normal coronary arteries in the setting of acute coronary syndrome. NSTEMI is non-ST segment elevation MI, smaller heart attacks, nevertheless dangerous. And STEMI are worst heart attacks, ST segment elevation MI. And we just simply looked at the data that was available. These, of course, were all data sets that had core labs. So we didn't have to guess about whether or not those arteries were open or closed, whether they had obstructive coronary disease or not. And what it demonstrated was pick a study or pick a category of acute coronary syndrome, all of which are threatened MIs or MIs. And you can see that women had 2 to 3 times the number of open coronary arteries compared to the men. Now, remember, in the 1980s, 90s, we knew what caused heart attacks. Those plugged up arteries, right? It's more so to the point where we had this whole system of bypass surgery and stents and drug-eluting stents and drug-resorbing stents, and yet it didn't look like that would be relevant in up to a third of women. So this was not a relatively small problem. So with that observation, and we designed the original and then 2 WISE trials to look at her story, not his story. And clinical translational research Our team defines it as a systematic approach to an identified problem. T1 is bench to bedside, but note I have the arrows going in both directions. We'll make observations at the bedside. Oh, look at that. A woman had a heart attack with no obstructive coronary disease. I wonder how that happened. So then we will go back to the bench and work with our basic colleagues. T2, of course, is bedside to clinic, so we start to do randomized controlled trials in humans that have the condition. And then T3 is that we do strategy trials. We demonstrate that it does or does not work in a real-world situation. And again, we can make observations at the community and go back and refine some of our clinical trials to make them more adaptable. So 4 steps: observation, mechanisms, intervention, and translation. So let's go forward with further observation. So we were curious about this paradox. How could women have heart attacks and acute coronary syndromes with no obstructive coronary disease? I had the great benefit of working with Dr. Carl Pepin, and he's remained a co-PI with me throughout. We described a phenotype where you can see the patient in panel A has exertional angina to the point where the treating physician has ordered a myocardial SPECT. This is one of our imaging. That is hearts. That is a little heart. And a cardiologist would tell you that is where the abnormal blood flow to the heart is, and that is what's causing the angina. And therefore, because that is in the left anterior descending coronary artery territory, let's do an angiogram and open up the artery. But it turns out the artery's open. The artery is wide open. Dr. Carl Pepin was a coronary physiologist, had grown up at the time where measuring flow and understanding flow in the absence of obstructive coronary disease was important and relevant. And Dr. Pepin said, let's put down some wires. We used to be able to do this before we became anatomists. And lo and behold, as we did more and more of this, these patients had an abnormal flow reserve. Their epicardial, large arteries, were open, so it is a small vessel problem. And these are the small vessels that you can't see. You can measure flow, but you cannot see them with the exception of some advanced imaging. We also did, which was highly novel at the time, intravascular coronary ultrasound, little tiny ultrasound probes going down into human coronary arteries. And what we demonstrated was diffuse atherosclerosis despite very smooth arteries, and again, typically in women. With our health economists and using a large data set, the NCDR, we estimated that 3 million people in the U.S. Had this. This was a much larger problem than breast cancer, and it was a lethal problem. And it's now called ischemia with no obstructive coronary disease. So for those of you that are in the coronary area or even the general medicine area, this is now acronyms, and there are billing codes for INOCA at this time. Working with another colleague, Dr. Martha Galati, who at the time was in Chicago at Northwestern, we needed a reference control group. We had women that we had followed now for 5 to 7 years, and we had asked, actually, NHLBI if we could include men as a control group, and they said no. So we found a control group working with Dr. Martha Galati, who had reference to a large Chicago asymptomatic women take heart study where these women were all studied, including exercise treadmill testing, which was negative. And what we demonstrated was these women had 12 times higher, a 12% 5-year combined MACE rate, and you can see the MACE MI, hospitalization for heart failure, stroke, cardiovascular death. So this was not a benign prognosis, which all of the previous studies had followed less than 100 women, and they had followed them for less than 3 years. So this was a bit eye-opening. Now, we've made some other observations. I'm going to just sort of spin through these. Working with Dr. Renu Vermani, who at the time was at the Uniformed Health Services Hospital, and she had a freezer full of sudden cardiac death victims. and who had all been necropsied to see, did they have a heart attack? Did they have some other kind of problem? And basically, in comparing women on the top, this cross-sectional of the coronary artery, compared to men, both had had heart attacks, both had had sudden death. It was very clear that women were eroding the fibrous cap of the plaque, where men were exploding. And the erosion will cause microthrombi, and we subsequently were able to demonstrate small non-segmental infarcts in these women, compared to men who would have a very large thrombus. They would occlude the artery and have a much more definitive heart attack. These symptoms often would come and go, might be called atypical, where this would be the classic Hollywood heart attack. And these were important differences not only in the plaque and the composition, but they contributed to this understanding that women had more, quote, atypical symptoms. What we now recognize is that women just have different symptoms. They're not atypical, and since 51% of the population is female, we might say they're the classic symptoms. So we also did this intravascular coronary ultrasound called IVUS. It was new at the time. And what we were able to demonstrate, and this is a cartoon that capitulates what we found with the Cleveland Clinic, because again, to get control male pattern, we had to collaborate with people. So panel A is a representative male. And the luminogram, when we do coronary angiograms, is depicted by this red. The pressure, meaning the flow, here is depicted in this line. And the plaque is the yellow atherosclerotic fatty plaque. And I think, a first-year medical student could tell you where the blockage is, right? If we're dealing with obstructed coronary disease, where would you bypass? Where would you stent? And that's the sort of classic male pattern. Sometimes we call it lumpy bumping, or similar to how men, when they become overweight or obese, they typically put it in one spot, right, in their viscera, sometimes called the beer belly. The representative woman at this point, she doesn't really have any obstruction, does she? But she's got plenty of plaque. She has remodeled her artery to be, the lumen often will be smooth, so a diagnostic luminogram, an angiogram, will not show you that. And yet her flow is just as bad as his flow at the end of the artery, so myocardium is not getting the oxygen it needs. And again, we analogize this to how do women, when they become overweight and obese? Well, it's that lovely cellulite, right? It's not visceral. It's smooth and maybe less harmful. We don't know about the differences in plaque here, but it was very clear that women and men were laying down their plaque differently in response to coronary atherosclerosis. So with those observations of these important phenotypes that were characterizing ischemic heart disease in women, we moved on to understanding mechanisms. And working with my partner in crime, Dr. Leslie Shaw, she's a health outcomes expert and an economic analysis, we said, okay, what would be sort of some testable mechanistic hypotheses, and we developed this hypothetical new understanding of ischemic heart disease in women. We, of course, were interested in a sequence, and we have followed some of these women now for over 20 years. The end game, right, is obstructive coronary disease, and we hypothesized that by the time women develop their subclinical atherosclerosis, that they have transitioned from a normal artery and a normal coronary flow reserve, that's what CFR stands for, to the beginning of an abnormal flow reserve. And for reasons potentially related to differences in hormones, differences in fat deposition, hypertension and lipids. We know that women are much more likely to have autoimmune diseases. That may be contributing. There are links to cardiovascular disease. And we know that women more likely have abnormal function. Women have more migraines. Women have more Raynaud's. So there were many mechanistic pathways that we could propose that might preferentially have women present with their ischemic heart disease as abnormal small vessel dysfunction as opposed to waiting until they become obstructive plaque. So we've gone forward testing these mechanisms. We again brought back with Dr. Pepin's help and got young investigators to be testing coronary function in our cath labs. This is invasive and requires an interventional cardiologist. It is a PCI or a PTCA setup. And then we brought in these Doppler flow probes that had been sitting in closets. And the interventional cardiologists all thought we were crazy. But we developed a sequential intracoronary testing where we can test 4 pathways. The coronary microvasculature auto-regulates itself like your computer in your car now. And so we could test each of these pathways, and people will be more or less dysfunctional depending on how many of these pathways are functioning abnormally. With these long-term follow-ups, as I've described, we've been able to demonstrate that women most often, 2/3 of the time, have non-obstructive atherosclerotic plaque. They almost always have endothelial dysfunction. We demonstrated that the impaired vessel dilation, this is the most serious adverse because it predicts the MACE as well as all-cause mortality. The increased epicardial vasoconstriction causes a lot of angina and it results in a lot of cost utilization as well as morbidity. And this is working with young investigators, fellows and postdocs who then go on to their own careers. So moving from mechanisms, then of course, we now can test interventions if we either repurpose drugs or devices that we already know works for some component of that mechanism, or even new drugs. So we of course wanted to understand, and again this slide demonstrates sort of how we got started. The gal on the right, of course, is Barbra Streisand. She is dressed up like a man, and for those of you that remember that movie in 1991 called The Yentl, she portrays a young woman who, turn of the century Eastern Europe, wants to be literate. She wants to learn how to read and write, and at that time the only people that could learn that were men. So she dresses up like a man. Dr. Bernadine Healy on the left, our prior but now past, unfortunately, NIH director and a clinical investigative cardiologist herself, opined in the New England Journal, I think the reason we're missing these women, why we're seeing this increase in death, is because they don't look like men. And so again, we started working to now translate these findings into something that would be relevant. This is an op-ed that we wrote in response to several European studies that were now replicating what we had found in the WISE. And again, a pictorial or a central figure demonstrating that when women look like men, when their angiograms look like men in an obstructive coronary disease male pattern, more men receive treatment. When women look like women, male or female pattern microvascular CAD, more women die. And this is because of a lack of treatment. We tested that hypothesis as we went forward with these pharmacologic probe trials. Guidelines therapy, if it looks like you have ischemic heart disease, is aspirin, beta blocker, ACE, and statin. These 4 pills, if you continue to take those pills, you will be seeing your cardiologist a year later. You will not have died from your cardiovascular disease. So this is very strong evidence, but it had not been tested in female pattern. We had incorporated increasingly this into clinical practice guidelines where if it mattered, if it looked like there was a female pattern that should be on a different decision tree in clinical practice guidelines, we worked hard to get these into guidelines. The guideline implementation, which was occurring around the time that we were doing these mechanistic trials, but this was sort of a good start and work done by another group, and it just shows you pre and post transition of the guideline implementation, much of this coincided with our American College of Cardiology guideline campaign. And basically, if you had an ACS or an acute myocardial infarction, you needed to leave the hospital on those 4 drugs unless there was a strong contraindication. This figure is not particularly understandable, so I've color-coded it. So following guideline implementation, the mortality for women improved, and the sex gap narrows. The male here, pre and post, really didn't change. Well, why was that? Men were already getting guidelines because, again, their angiograms were something that the doctor could diagnose and say, I know how to treat that, and they got treated. The persistent sex gap, small but real, and we're talking about hundreds of thousands of lives every year in our country. The persistent sex gap suggests that more work is needed to understand sex-specific pathophysiology to improve these outcomes in women and men. So just with guideline campaigns alone, before we really knew how to treat this, we saw a pretty dramatic improvement in cardiovascular disease death rates in women. It was also going down in men, so might have been something in the water. But we like to think that these guideline campaigns really have been demonstrated to save lives. And what we saw clearly in the women, which had been previously heretofore still going up, right, that a 43% in cardiovascular disease mortality. So concurrent with this Good Guidelines campaign, we launched these intervention and we called these pharmacologic probe trials. Why? Because we had drugs, sometimes devices, but dominantly drugs, that we had known pathway effect. So using pharmacology to then tease out mechanistic pathways. And what we demonstrated early on is ACE inhibitors. Quinapril is a commonly used angiotensin-converting-enzyme inhibitor. Not only improved the coronary flow reserve in the small vessels, but was anti-anginal at 16 weeks of treatment. Nobody would have thought that this drug would improve angina. Others were not so successful. We tried low-dose hormone replacement therapy. I'm always happy to take questions about HRT, but I will just tell you, women are not just hormones. And we learned that lesson. We didn't have any adverse effects. And we think that they thought their angina was better because their hot flashes were better. EWISE, aplenerone, did not add. SY sildenafil, a PD5 inhibitor, did not appear to help. And an early use of a drug, ranolazine, only one in its class, nobody really knows how it works, didn't seem to work. So we had our work cut out for us then to try to translate this. So now that we knew, and previous work done at Mayo and the Brigham had demonstrated high-intensity statins, we worked then to translate this. So this is the Warrior trial, which is ongoing. Women's ischemia treatment reduces events in non-obstructive CAD. The investigators, as you can see, are listed there. As designed and funded by our congressionally directed medical research program of the DOD, 4,422 subjects with angina and no obstructive coronary disease randomized to intensive medical therapy, which is high-intensity statin, maximally tolerated ACE or ARB, versus usual care, and that was for the outcome reduction of MACE, which was all-cause death, non-fatal MI, stroke, hospitalization for angina, or heart failure. This is the point of care randomization. This is open label, done in the clinic using repurposing FDA-approved drugs that are easy and very economical now in cardiology and used every day in cardiology and internal medicine offices. And usual care, we did not interrupt any care, but we heightened care in the vast majority of patients. This has relevance to another epidemic called a type 2 MI. We talked about NSTEMI and STEMI. but we are having a sea change of heart attacks moving away from the STEMI MIs, probably because of the widespread use of statins and over-the-counter aspirin, to type 2 myocardial infarction, rise and fall of cardiac biomarkers, evidence of ischemia, but it is due to a mismatch in the myocardial oxygen supply and demand, and typically open arteries, vast majority of the time. It is dominated by women, but not all women. But you can see here, or excuse me, not always women, because type 1 MI, the good old bad STEMIs, plaque rupture, mostly male. Type 2 MI, mild or no plaque, or fixed, but not a plaque rupture, and this is dominated by women. Because we had done all this study in the WISE, we do think that this is helpful, meaning we are now informing, because we did this deep phenotyping, we have much better mechanistic understanding that we now are able to, for example, help with these use in practice, low type 2 MI risk, high type 2 MI risk, and ongoing and starting trials now are testing how should these patients be treated. These patients appear to have minimal risk. So better phenotyping, better precision care, and hopefully better health as a result of randomized controlled trials. The type 2 MI also thanks the study of women and Herstory because we have new chest pain guidelines that just came out a year and a half ago, and we have, as I mentioned previously, new ICD-10 codes, so now physicians can actually bill when they treat these conditions, which previously we didn't think they were real. So faced with a patient with non-obstructive stenosis, it is very clear now that they should be treated. They should be given medications because they've had a heart attack, unlike our Warrior trial, and that the physicians now can use these codes, and they understand also how they would diagnose this patient. This was a central figure with my colleague, Dr. Martha Galati. Another example of guidelines impact and return on investment, economists at the Congressional Budget Office had described a huge reduction in its Medicare forecast between 2010 and 2020. Most of these reductions came from changes to public health and the practice of medicine itself. And specifically, older Americans are having fewer heart attacks and strokes, and the likely result of effective cholesterol and blood pressure medicines. And so this is an example, again, of NIH and return on investment. And we need to just pound that drum all the time. Every time we are asking for budgets, we're asking for resolutions, it's critically important. So here's where we were then as we did these pharmacologic probe trials. As we started to get into these newer guidelines and newer coding, once again, we saw a drop to the point where women now were at parity with men, shown in the red line compared to the blue line, asking, is this optimal for women? Because women used to do better than men, and women continue to have a longer lifespan on average than men. Sort of built to last might be one of the physiologic differences. And so that is the question. Should it actually be down here? Is there more work to be done? And indeed, even before the pandemic, and associated, as we read, on deaths of despair and eroding lifestyle practices, both women and men's cardiovascular disease is on the rise and was aided and abetted by the pandemic. So for those of you in cardiology, cardiovascular disease, and all of its related disciplines, we are assured of a job, unfortunately. Yeah, more work ahead. All right, so Not Your Father's Heart Disease, the Herstory, and the NHLBI sponsored WISE. Observational studies continue to demonstrate that INOCA, ischemia with no obstructive coronary disease, is common in women. I didn't show you the data in the interest of time, but it's common in young midlife women, premenopausal women, meaning between the ages of 45 and 55. Mechanisms include traditional cardiac risk factors as well as these novel sex-specific risk factors. And our interventional trials, our pharmacologic trope trials, support traditional and novel interventions. And translational work is ongoing to promote investigative findings into guidelines and clinical practice to improve human health, as well as eliminate these sex-related cardiovascular disparities. This is where we are in terms of getting up into a more contemporary area. And it is paralleling the decline, the red line, in cardiovascular disease. Again, trying to help us all understand return on investment and why investing in women's health in particular, recently acknowledged by the White House, is critically important, not only because it's the right thing to do, but it turns out to be a pretty good economic investment. We are continuing in our WISE studies on the basis of the heart failure prognosis. If you recall one of those early slides in the observation section, that the majority of adverse events in these women are not heart attacks, although we may have missed them because of the lack of the time at high sensitivity TNI, troponin, but they clearly go into heart failure. And so this is probably the fodder for heart failure with preserved ejection fraction, which is a new epidemic of the last 20 years. And these are investigators working with us collaboratively and on our team to understand pathways to heart failure with preserved ejection fraction, fondly termed HFpEF. And we are working very hard at understanding not only subendocardial ischemia, but and documenting that the tissues are actually ischemic using MR spectroscopy, but also looking at why does the heart get stiff, and it appears to be infiltrated in many of these cases with triglyceride, actual fat in the heart muscle, potentially due to metabolic dysregulation and a shift from free fatty acids to glucose in the hibernating myocardium that is oxygen starved. We're also looking at adverse remodeling and more diffuse fibrosis in addition to focal fibrosis, which is shown right here, late gadolinium. And then looking very carefully at not only strain, how much the heart squeezes and twists, it is pumping, but also how the ventricles are working synchronously or dysynchronously, and how the atria and the ventricles are working together. And all of these are potential mechanistic treatment targets, again, for novel or existing interventions. This is our benefactor who raised the money by getting her network to endow our center for research and policy. Education and policy and research, things that we will need seed monies for, and then the education and policy, because we cannot write grants for that. So that might be my last slide. Here's my last slide. So I always want to thank our participants, and I'm always happy to talk to investigators because the mantra is that you cannot get women to volunteer for research studies, and we have not found that to be true at all. And so I'm always happy to give you tips. Starting with some female investigators is a good first start. I want to thank my clinical team who does this important work with our patient participants, my administrative team, and my collaborators, as well as my clinicians in our center. Okay. So I'm ending on time.
Okay.
I'm happy to take questions.
Thank you. Well, we certainly welcome questions from the audience. To get us going, actually, I wasn't able to type it in yet. There was a question about participation in clinical trials. So maybe you can expand on that last tip you said.
Excellent. So now, if it was a specific question to the Warrior, enrollment did end in December and will be closing follow-up out by June. We had, because of the pandemic, as you might imagine, we were limping along, but we did not stop. And so we're somewhat under-enrolled. We went through, thank you, DOD, 3 cost extensions. But we are finishing, and we will have results at the AHA this coming fall. So unfortunately, the question is you cannot enroll in that particular study. And then all of our other studies, please shoot me an email, and I'm happy to, take referrals of patients or even yourself. We have historically done well for enrollment. I think the tricks are, number one, you can see on this page a fair amount of female leadership. And just like that PNAS study that demonstrated that female emergency department physicians were better at taking care in terms of outcomes, morbidity and mortality of heart attack, if it was congruent, if a woman doctor was taking care of a woman patient. I think for reasons that are probably related to that, our women feel pretty confident about, enrolling in our clinical trials as well as our observational studies. So having female investigators and staff on your team, not exclusively, as you can see, we have men as well. Number two, the protocol needs to be female friendly. We offer stipends for travel. We have stipends for days away from work, for elder care or child care. And you can't have these enrollment criteria where no one over 75 can, can't. A lot of over 75 women would like to participate in a heart failure trial. So the protocols need to be female friendly. These are not that hard to do, and yet when you look around, they're not done very often. So I hope that's helpful.
Yeah, very insightful, yeah.
Thank you for a wonderful talk. My name is Alan Romali from Heartland Blood Institute. I was very curious, the last slide that you mentioned, the triglyceride infiltration in cardiac tissue and patients with heart failure. Is there any association with triglyceride-rich lipoproteins themselves with that finding?
Yeah, that's a great question. So far, no. And also the other obvious question is that those are the diabetics, right? That they're the ones that have the high circulating blood glucose, and that doesn't appear to be true either. We got the idea, well, we had a spectroscopist, and she was very interested in this. And we went to the literature, and there are, one-off unusual genetic disorders, often children, where they cannot use free fatty acids. They use glucose as the primary metabolic fuel. And it's turning out to be true. We are halfway through her R, Dr. Janet Way's R, so we'll see how much it turns out to be true. But so far, no, it doesn't appear to be related to that.
It'd be interesting to take a look at Ira Goldberg's work from maybe 10, 20 years ago, where he did PET scans in patients with lipoprotein lipase deficiencies, and showed switching from fatty acid to glucose may change gene transcription in cardiac cells, and maybe that's a link there.
And maybe that was one of the things that we looked at, that we saw some experiments of nature, right, that we wondered. And again, these patients clinically often have chest pain at all rhyme or reason, not always exertional chest pain. And with our current cohort that we're finishing, we've also demonstrated that by just something simple as hand grip, they leak troponin. And so the idea is, if you do this long enough, they may really genuinely have a form thrust of what we would call hibernating myocardium. There are cells that are just hanging on by their fingernails, and the least amount of effort can cause damage, and then shift in metabolism, right? We think you can tell us if that's a known mechanism, but more importantly, these small late gadolinium scars, we think, and the fibrosis.
Thank you.
Thank you.
Thank you, Noel. That was a great talk. I'm interested in the type 2 MI.
Yeah.
So is flow reduced? Is flow reduced in that?
So type 2 MI, again, defined at a raw phenotype, is, they have a rise and fall of the troponin, so it's not a constant. And that, the mechanistic understanding is that the demand outstrips the flow. And so it's an imbalance. So what would be a common type 2 MI? Urosepsis. So extreme oxygen demand, right? You're in shock. Everybody's starving. Nobody's getting enough oxygen. And so as much as they can vasodilate and try to deliver that oxygen, it outstrips. So that would be one mechanism. But we also see type 2 MIs where the demand doesn't look that stressful, right? And so then we would hypothesize, and this is work that needs to be done, right? Because the type 2 MI has only recently been started. You know, it's another one of these, we have to wait 10 years for the epidemiologists to say, whoa, this is an epidemic. We're having an epidemic of type 2 MIs. Go study it. And so how many of them are going to be in those different camps? They tend to be older, but again, we may be missing type 2 MIs in women because of the male pattern troponin threshold.
And I wonder whether there's a metabolic component to it, that's part of the reason. It'd be interesting to look at.
It absolutely could be, because, you know, you'll see people, 55-year-old woman, you know, they have the same age, they have the same risk factors, they have the same menopausal status, and yet one gets into trouble with this flow reserve and has INOCA and maybe MINOCA, and the other one's just fine. She's hypertensive, she's got the same issues, but so I think that's exactly right. And the omics may help us understand that. Yeah. Sir?
Yes, very nice talk. Question is, how does lipoprotein(a) factor into your population and women versus men?
Yeah, great question. So if my colleague, Dr. Martha Galati, was here, she would say, this is such a big problem, and thank goodness these drugs are coming. So I have to tell you there's some controversy in the field. Noel, who worked when the CDC was working with the National Cholesterol Education Program to certify the nation's labs for that standard lipid panel. Because, you could send split samples to, 2 different labs and you would get totally different results. At that time, with George Mensa, the Lp(a) assays were up for also standardization, like everybody had to do it the same way. And it fell off the radar and was not implemented. Ditto homocysteine, same thing. Homocysteine is a real problem for laboratory variability. Now that this is coming out, future drugs are in phase 2, phase 3. It's going to be an issue again. And so far of the people that I've talked to, that nobody is suggesting this, or no work is being done at authoritative levels. So I would be a little skeptical about who's really high. The other thing that industry is going to want to sell us these drugs, and they're going to say, okay, well, even though it's only 1 in 100 or 1 in 250 that has a high enough level that we would enroll them in a clinical trial, they're going to say it's going to be a continuous scale. These are going to be really expensive drugs, and I would be cautious about how much this will play out. Happy to be wrong, but I think so many of these other targets are going to need a precision medicine diagnostic to really understand who's at risk and who's not for these super expensive drugs.
Thank you.
And super expensive, $200,000, $250,000 a year, like some of these oncology drugs. Yeah, that's my take.
Dr. Bailey, thank you so much for such a wonderful talk. And I have a question there. We know that HDL functionality varies also. It's different between men and women, and even in women at the same time, pre- and postmenopausal, due to also hormones. But here, my question is, in any of your studies, was there any association between, I know there may not be like any HDL functionality test, but on HDL, it's HDL-C levels in between developing an INOCA or MINOCA versus developing a whole obstructive STEMI?
Yeah, another good question, and another area that we actually have HDL drugs that are, not expensive. Niacin is a great drug, hard to take, but it's a great drug and it's cheap. I mean, if you were on a desert island, you might wish that and you could only have one drug, you might wish it was niacin. And so there's actually been a lot of work in HDL, and it's pretty much a big fat nothing. All of the HDL raising drugs don't do anything good. HDL function is very hard to test, so that has not been scaled up to clinical trials. It has to be done on live blood, like platelet function. Same thing, we don't have a lot of platelet function tests in big clinical trials. And then the work that we have done in INOCA-MINOCA is a very well-reproduced J-shaped curve. So there is increased cardiovascular MACE, morbidity and death, in very low or low HDL and very high HDL. And the thresholds for women are under 50, that would be considered low HDL, and over 70, which is considered high HDL.
But in developing obstructive or non-obstructive MIs, is there a difference in HDL-C levels?
Well, that would be a good question. We could look at that. Okay. Because we have in the original WISE cohort, again by design, because they wouldn't let us have men as controls, we included about a third of that original cohort that did have obstructive coronary disease, and we have the long-term follow-up on them. So I'll have my fellow, that's Dr. Ranasinghe, one of our current fellows, just published in American Heart Journal our J-shaped curve that replicates something that's been seen in epidemiology in general cohorts, but we, again, have the INOCA-MINOCA cohort.
Thank you.
Okay, good. Yep.
Really great talk. I was just wondering, with Ozempic and other drugs, I guess for weight loss, that have been authorized, has that affected your patient cohort and the incidence of INOCA and other, the development of atherosclerosis in these patients? Yeah,
this is a great question. So these are the GLP-1A meds, and there's 4 on the market now and more to come. There's tremendous interest and excitement. They were originally developed for diabetes. But because the FDA, because of the sulfonylurea problems, right, of controlling blood sugar, but, oh, by the way, killing the patient, they required that industry develop these drugs with very careful cardiovascular monitoring to show that it was safe. And lo and behold, these drugs, as well as the SGLT inhibitors, have been shown to be effective for reducing cardiovascular morbidity and mortality. Not only safe, effective, and they're increasingly getting approved for that indication. So these diabetes drugs, and it was known, it's a known mechanism, right, of interfering with the gastric hormone process, that people eat less. There's nothing magic about these drugs. They just get people to eat less. So I've had these arguments with patients. I'm like, it's just the same as eating less. No, it's not, doctor. It's a miracle. I've struggled my whole life and I eat nothing. So that's the class of drugs that he's asking about. And when we look at our INOCA-MINOCA population, they look just like America. So half of them are overweight, and then a smaller percent are obese. And so about 60% of our patients, just like Americans, are either overweight or obese. And they want these drugs. Dr. Martha Galati is our preventive cardiologist. I'm a little bit of a naysayer, as you could see with the Lp(a) issue. I'm a little bit like, show me the data. Here's the data so far. These were approved and been available for about 2 years. At the end of 1 year, 26% of patients are still taking it. When you stop taking it, the vast majority of patients regain the weight. We've had a lot of problems with worsening insurance coverage as this market has just exploded. And So, for example, Medicare, if you talk about cardiovascular disease, a majority of patients will be Medicare age. You have to meet criteria, but then you get funded, and that might be the 26% that actually get it covered. A lot of the indemnity insurance, I had one patient, diabetic, lost the weight, A1C normalized, drug company says, we won't pay for it anymore because you're not diabetic. Yeah, and the last reason that I'm a little bit, show me the data, show me the long-term data, because overweight and obesity is a chronic illness. What happens when you lose weight, let's say you lose 10 pounds, you've lost 6 pounds of fat, but you've lost 4 pounds of muscle and bone. And what does the average adult do when they regain weight? Do they go to the gym and exercise and, do weight training and aerobic? No. So when they regain the weight, this again is well documented, it's almost all fat. So this weight cycling potentially will contribute to frailty and increased aging. So, and there are no guidelines yet, and because there's no data, about the runway. Like, how long can you take these drugs? What happens when you weight cycle? What happens when you hit your goal weight? They're trying to, they're working right now to get the semaglutide oral, and that might be a off-ramp, might. So I'm expressing some concern, except for my very high-risk patients, and then I send them to Dr. Galati because she likes doing it, battling with the insurance companies.
Thank you.
Thank you. Wonderful talk. So DVT is a well-known side effect of oral contraceptives, and I was wondering if in premenopausal women in your study, if you found any association between microvascular complications or increased microvascular complications and their status on oral contraceptives.
Mm-hmm. Good question. So we did a whole line of again, observation, but looking for mechanisms to try to understand how much endogenous hormones, as well as exogenous, which would be the birth control pills. And we basically didn't find very much in terms of exogenous hormones, risk or benefit. These are cross-sectional and prospective analyses. They're not the same as randomized controlled trials. But my take-home would be, it looked like the birth control pills were probably relatively safe in these INOCA and MINOCA patients. I'm not saying I would prescribe them, but we didn't see evidence of serious harm in 1,000 patients followed now for 20 years, but only probably 30%, 40% were premenopausal. And how many were taking the birth control pills, I'd have to look it up. So I'm not sure that that would be enough to say these are super safe to use. What we did find in endogenous hormones is a very high prevalence of what we now call hypothalamic hypoestrogenemia. And these are younger women, premenopausal women under the age of 50. And they typically will say they have menstrual cycles, but if you actually have them track them with an app, they have a lot of missed periods. They probably they are having breakthrough bleeding rather than nice, regular ovulatory cycles. This was associated with accelerated atherosclerosis. Who has hypothalamic hypoestrogenemia or amenorrhea? Some of them are amenorrheic. Can't talk today. They are more likely to be stressed, more likely to be diabetic, more likely to be athletes, high-intensity athletes, very lean, some eating disorders. So we did find that, and that is probably, in our estimation, this is working with Dr. Cassandra Schufelt now at Mayo, this is probably bigger than PCOS, this hypothalamic amenorrhea. Did I answer your question? Okay.
That was perfect. Thank you so much.
Okay, thank you.
Okay. Hi, thank you so much for your talk. Something that I was wondering is, would you expect someone who's like a transgender woman, so like someone who's been taking estrogen therapy, I'll say like for a long time, maybe like at least 5 years, to have the same, I guess, propensity towards the non-obstructive MIs? Or do you think that there's more to it than just like estrogen or testosterone being in the bloodstream?
This is a good question, and I actually have data to answer that. We were interested, again, early on to try to understand these reproductive hormones, right? Because that, I mean, it makes intuitive sense. What are some basic sex differences? If you were going to study women, you would study these reproductive hormones. So we had an experiment sort of nature because I had worked a bit with Eric Villain at UCLA, and he had a cohort of transgender women, so men who had transitioned to being women, and they had all agreed to research, and he already had them in a cohort study. And we wanted to understand the data from Denmark because they had been doing transgender healthcare, allowing people to transition for over 50 years, and they had long-term follow-up studies where the transgender women had accelerated cardiovascular disease, were dying prematurely, where the transgender men were not. And so that was an important sex difference, right? And their records were pretty good. It seemed, reasonably believable. And so we invited Eric's cohort to come and do insulin. We did deep phenotyping, and we did cardiac MRI. And again, we were pretty interested in this myocardial triglyceride as well as all the other things that we do with MRIs. And then the last thing we did was we kept going to just above the kneecap so we could say that they had or had not retained their testicles, right? And we also did complete hormonal profiles. And the vast majority of them had not only fatty liver, which was known, they had fatty heart. They had premature coronary atherosclerosis, and they were very insulin resistant. And then what related to a lot of this was the crosstalk between their estrogen and their androgens. And those that had retained their testicles had a lot more of this dysmetabolic ism, right? So we published that. We tried to get an R01 funded, and at the time, it was in the Bush administration. It wasn't politically correct. Does that help?
Yeah, thank you so much.
Okay, very good.
Maybe one last, lots of questions
Okay.
online, but we covered a lot. But just maybe one topic we haven't touched on. How does pregnancy affect long-term health? In your study, were you able to compare women with pregnancies and women without pregnancies?
Yes, we did. We have looked at that as well. And we replicated what's pretty well observed is women that have no children, and I'm not saying this is, a political statement, but they tend to have not as good health as women that have at least one child. That J-shaped curve has always been true. And then after about 4 or 5 children, health becomes, premature health is a problem. We don't know, because our WISE women, again, recruited by the 1980s and early 90s, they were just at the tip of the 1960s oral contraception and women finally being able to self-manage their own fertility rate. So it's a challenge to the next generation to study cohorts and not the women's health, because they're the same as ours, and not the women's study, the Joanne Manson. Somebody's got to do a big study. We're sort of doing this with the New Mom-to-Be, another big NHLBI sponsored study. But the point is, when women choose not to have children, that's probably different from women that are infertile. And because fertility, once again, is a holistic health predictor. And then you might ask why, when you get more than 4.5 children per woman, and that was the Elizabeth Barrett Connor, the pizza hypothesis, that as soon as you have more than 4 children, you just eat pizza all the time. All right. Yeah, thank you. Speaking of...
Yes. Well, thank you very much, Noel, for that wonderful talk. And there are some refreshments outside, so we should join them. And also we're not presenting the plaque, but I just want to acknowledge this nice plaque that will be sent to you. And thank you all for coming in person. This is wonderful, and enjoy cookies or fruit or something outside.
Good.